Great start. Okay, so yesterday we started talking about ultrasound physics, and basically how this works is we have an ultrasound machine that generates sound waves, and the sound goes inside the animal and it bounces off of things. And then some of that sound reflects off of different structures, goes back to the ultrasound probe, and then in turn goes back inside the ultrasound machine, and magically it makes a picture out of it. So that's how things in general, how it works. Unfortunately, we have to get a little bit more specific than that, but that's in general kind of how things work. Then we talked about early on, sonar was one of the inventions that led to ultrasound. And sonar is an acronym, again, that stands for sound, navigation, and ranging. We use sonar now is, for maritime purposes, also in boats to fish finders and depth finders and things like that. We said that it would unsuccessfully tried to use sonar in about 1912 to find the Titanic on the bottom of the ocean. Didn't work out so well. They used it much better, more successfully in World War II, mostly by the Germans, to find our submarines and sink them. Medically, in the 1950s or so is where medically we started using ultrasound. And of course, it started on the human side. In veterinary medicine, probably in the early to mid 80s, some of the vets started and vet schools started to get ultrasound. Of course, back then those machines were huge. And also the image quality from those machines was, compared to today, was really poor. But everybody thought it was pretty cool at that time. Now I would bet that about 50% of veterinary clinics have ultrasound, but the key is how many of those really know how to use the ultrasound to the full extent. Unfortunately, every day I hear stories of veterinarians that get convinced they want to learn ultrasound. They go buy an ultrasound machine, sometimes spend $30, $40, $50,000 on an ultrasound machine, and then they get busy, and unfortunately they don't take the time to learn how to do ultrasound or practice it enough, and then before long the machine sits in the corner of a room and collects dust, and or they may use the machine only to get urine or to look for bladder stones, and that's about the extent of it. So here's an example of a boat sitting on the top of the water, and this boat, you can see, sends out these volleys or pulses of sound, and that goes in all directions inside the water. And in this case, the water is the medium in which sound travels. Sound has to have a medium in which it travels. So as these sound waves come out and propagate through the water, they bounce off of different things that are either in the water or the bottom of the ocean or bottom of the lake or whatever. And when they bounce off or reflect off of those structures, a portion of that sound wave then emanates and goes back to the bottom of the boat where there's a transducer. And that transducer then converts that pulse that's reflected off of that structure into a picture or a blip on the screen to tell you that there's something there. So if we get a little bit more in depth, sound waves are a wave property of energy, just like electromagnetic energy and light and things like that. So all of us have had physics in undergrad, and we kind of remember some of these concepts. And so every wave that is form of energy can be described with different properties. They all have a velocity, or how fast they go, the frequency, how often they go. They have period and wavelengths and amplitudes, which measures how apart they are and how high they are. With ultrasound, the velocity and the frequency is the thing that's most important. The other ones we don't really worry about a whole lot. And again, like all sound, it has to have a medium in which it travels. So right now, the medium in which my voice is traveling is air that's in my room. If somehow I evacuated all the air out of my room and it was in a vacuum tube, I could be talking and you wouldn't hear a thing. So you'd probably be better off than you are right now. The speed of ultrasound and any kind of sound wave is dependent on what type of medium it's traveling in. So if you have a medium that the sound is traveling in and it's not very dense at all, like air, then sound travels relatively slowly. On the other hand, if you have a medium that the sound is traveling that is really dense and kind of hard and stiff, such as bone or metal, then sound travels much faster in those type of things. Okay, that's about where we left off yesterday. So now we've had a review. So we're going to continue on. So the velocity of sound in different mediums is very different. So in air, you can see the velocity of sound goes at about 331 meters per second. In soft tissue, sound travels about 1,540 meters per second. And it varies a little bit depending on what body structure it is. Kind of the more meaty, it will be a little bit faster. Okay. But in general, all of this is close enough. And we consider that the sound wave in all of soft tissue in the body is 1,540 meters per second, that number right there. If you get down here into, again, things that are hard and stiff like bone and metals and things like that, you can see the sound travels much, much faster in those type of structures. So we're down to this: ultrasound travels 1,540 meters per second in soft tissue or water. The word ultra in the word ultrasound means that the frequency is too high for a human ear to hear. Generally, humans can't hear anything more than about 20,000 hertz in frequency of sound waves. When you're young, you might be able to hear a little bit higher than that. When you get older, that number comes down, and so ultrasound is much higher than this. Ultrasound isn't described usually in the thousands of hertz, but in the millions of hertz. So it's not only too high to hear, but it's much, much too high to hear. Okay, again, talking about frequency, you have to get this concept down too, is there is a trade-off that's inherent because of the physics of how sound waves propagate through whatever medium it's traveling in. You can remember this, I'll give you a good example here in a minute, but in general, low frequency sounds, and that would be the bass in a speaker, will travel very far, but the resolution of that sound is not very good. The opposite is true for high frequency sounds. So the trebles, cymbals, things like that, and sounds that come out of the tweeter part of the speaker, those sounds don't travel very far, but they sound better. Okay. And the easy way to remember this, and this is the same holds true for ultrasound, is that if you are sitting in your house right now and some 18-year-old kid pulls up in his car and he has his radio blaring with his subwoofers and his amps and everything else, the sound that you're going to hear, if he's got that up really loud, what do you hear? Do you hear nice crisp trebles and things like that, or do you just hear boom, boom, boom? Right, that's what you hear, and that's because the low frequency sound, or the bass, has the ability to penetrate through his car, through his windows, through the air, into your house and into your head. Okay. On the other hand, you don't hear the trebles. You don't hear a lot of that stuff. All you hear is boom, boom, boom. And that's because the higher frequency sounds don't have the ability to penetrate a far distance. Okay. And also, if you listen to that bass that you would hear, does the bass sound muddled and poorly defined? Is it just all kind of blends together, or is it crisp, tight bass? It's not crisp and tight. So the resolution of that bass is poor. Okay, and that goes along with low frequency sound, the properties of low frequency sound and how they penetrate. So if we take our speaker analogy again one step further, if you've ever take the grill off of a speaker and watch the big part, which is this thing here, the woofer, as you turn the volume up, what is that woofer physically going to do? If you watch it, what does it do? It moves in and out, right? So it moves in and out. And so as it moves out, it generates what's called a compressional wave in front of it, in the air that's in front of it. Okay. So it generates these compressional waves that are separated by a distance as this speaker moves out. Once the speaker moves out, then it moves back in. And when it moves back in, it generates these areas that are between the compressional waves. And these are called areas of rarefaction. Okay. So every speaker, as it moves in and out, will generate compressional waves that are separated by some type of wavelength. If you have an ultrasound probe that is a 3 megahertz probe, and you compare it to one that is half that, 1.5 megahertz, then the ones with the 3 megahertz probe will generate twice as many compressional waves as the one that's half that. Okay, so bottom line is, every time you have an ultrasound probe and you're sending sound out into the tissues of the dog or the cat or you, it generates compressional waves that are separated by areas of relatively no sound. Okay, so it's these pulses of sound that tend to come out. Whenever we look at x-rays or CT or MRI or ultrasound or pictures of you for that matter, we always want the best resolution we can, which means we want a nice, crisp, pretty picture. Okay, it doesn't do anything if it's out of focus or the edges are blurry or fuzzy, or nowadays with computers if it's pixelated or noisy, right? And so we always want the highest resolution. Well, resolution is picture-wise is defined as the ability to distinguish two different objects that are right next to each other, and you can still tell they're two objects. So imagine that if you had your computer and you walked 25 yards away, and you looked at these two pictures down in here, these blue squares or rectangles, and these two blue squares or rectangles. If you were 25 yards away, you might be able to see that these still are two separate ones, because there's enough big enough gap between them to where you can probably still see there's two separate ones. So you have the ability to resolve that there's two separate rectangles, right? On the other hand, if you looked at these, the further away you get, there's not much gap between these two rectangles. And if you get far enough away, this one's probably just going to look like one big square, right? And so with ultrasound, we want to be able to distinguish two little bitty nodules that you might see in the liver, let's say, and they're very small. They're 1 or 2 millimeters big, and they're right next to each other. But obviously, intuitively, you would think that the better picture, the more diagnostic picture is going to be if I can define those edges and still be able to see that there's two little ones right next to each other instead of one big glob, right? So there's two types of resolution. Well, I'm not going to get really in depth into this, but there's two types of resolution that we want to define. So horizontal resolution is if we have two nodules that are right next to each other, right to left. Okay. Axial resolution is if we have two nodules that are stacked on top of each other from front to back. Okay. And both of these types of resolutions, you want to maximize the resolution in the horizontal plane and the axial plane. Okay, I'm not going to get into that. I'm not going to get into that. Okay, so dual function of transducers. When you have an ultrasound probe and it's turned on and activated and it's sending these volleys or pulses of sound into the body, generally what it's doing is 1% of the time, it's actually sending out sound. The other 99% of the time, it's listening for incoming sound. If you remember, what is the definition of a transducer? Do you remember that from physics or from physiology? You might have talked about this. A transducer is a mechanical device that converts one form of energy into another form of energy. Okay, and so the ultrasound probe or the transducer, it actually has multiple functions. It takes electrical energy that comes out of the ultrasound machine, and it converts electrical energy into a sound wave or a pulse of energy, of sound energy. And then it does that only 1% of the time is it actually sending out pulses of sound. The other 99%, so the great majority of the time, it's not sending out sound. It's listening for incoming sound that has reflected off of things inside the body. So it spends most of the time listening for incoming sound, and just only a small fraction of time that's actually making sound pulses. I'm not going to worry about that for you guys either. Okay, so this one here, we do probably need to worry about a little bit. If you had a flashlight and the lights were turned off in your room and you turn the flashlight on, it would send out light, right? And that light is just like ultrasound. It's a wave form of energy, but it's in the visible light spectrum that we can see, right? And so if I have a flashlight and in the dark and I put it 6 inches away from a wall and I turn it on, is the circle that you're going to see on the wall, typically at 6 inches away, it's going to be pretty crisp and round and well-defined. The edges are going to be well-defined, right? If then I back up and I pull the flashlight, instead of 6 inches away, I go to 6 feet away from the wall. What is the circle now going to look like in comparison? Well, the circle is going to be bigger and the edges are going to be fuzzy and less distinct. And that's because the more distance between the thing that is generating the light energy, or with ultrasound, the sound pulse, and the structure that you're trying to see, the more distance there is, then the fuzzier that area is going to be, and the sound wave or the light will diverge. Okay, so it gets bigger and bigger, just like the circle on the wall gets bigger. So in the near zone, with ultrasound, if this is the ultrasound probe sitting on the skin surface and sending sound from left to right, in the near zone, and somebody named Fresnel, I guess, defined this on the human side. You know, the human physicians are funny because every time they find out something, they like to name it after themselves because they have these big egos. In veterinary medicine, they just say the near zone or the far zone. Okay. So in the Fresnel zone or the near zone, that light or that ultrasound that's coming out of the probe will be very well defined and gives you a nice picture. On the other hand, the farther the distance is away from the surface of the probe into the tissues, the sound diverges, just like the light did from the flashlight, and the edges and everything just becomes more fuzzy, and there's the picture isn't as pretty. Okay, so you have a near zone of an ultrasound image where the picture is going to be the best, but the farther away you get deeper into the tissues, the picture kind of falls apart. So ideally, we would like to have a mechanism to where we can focus that near zone into a little bitty beam of energy, okay? The more we can focus it at different depth levels, the prettier the picture is going to be. And so almost all ultrasound machines that you will buy now, you will be able to electronically adjust a button on the machine to cause the focal level to become at different depths. So you can adjust it into the near field or even down in the far field and maximize the resolution of the image and make the image quality better by adjusting where that focal zone is. I'm not going to worry about that or that. Okay, now we're going to go into transducers and how they work. So did everybody survive that very, very brief physics part? Okay. So transducers, again, a transducer is something that converts one form of energy into another form of energy. And with ultrasound probes, that is the transducer. The transducer is actually inside the probe. People use the word transducer and ultrasound probe synonymously. So in this particular case, the ultrasound, just like we said before, the ultrasound transducer takes electrical energy, converts it to sound energy, waits for incoming sound energy, and then it converts it back into electrical energy and feeds that to the ultrasound machine so it makes a picture out of it. Okay. There's different types of probes out there, except nowadays there's really only one type that you're ever going to see, is you're going to see these probes that are electrical probes. Back in the day, they used to have mechanical things, and there's things flipping inside the probe and moving around and balls turning and stuff like that. You don't see that anymore. Every probe that you'll ever see now is an electrical probe or non-mechanical probe, which is a good thing. Okay, also realize that the physical size of the ultrasound probe has nothing to do with the frequency. So I could have an ultrasound probe that is the size of a eraser on a pencil, and it can be a low frequency probe or it can be a high frequency probe. So you can't tell by looking at the size of it what type of frequency is going to come out of that probe. Okay, small footprint probes, and the footprint of the probe is, people describe that as the part that actually touches the skin. So a small footprint probe might be the size of a quarter in diameter that touches the skin surface. A large footprint probe might be the size of, if you ripped a dollar bill in half, it's kind of that long, okay? And there's reasons why you would want to use both of these, okay? If you have a cat and you're trying to look at the heart and you have to shoot between ribs, and those ribs are a centimeter apart, it makes more sense to have a little small footprint probe to do that than some big probe that's unwieldy and you have to put on the entire side of the thorax of the cat. On the other hand, if you have a 150-pound St. Bernard that you're trying to ultrasound the abdomen, it might make more sense to have a large footprint probe because you get this bigger panoramic view that shows the liver in one side and the spleen in one side, and you can see different things and compare them all together instead of using a smaller footprint probe. So there's a reason why you want small footprints and big footprints, depending on what kind of animal that you want to do. So here's an example. There's a penny, so you can get the idea. This pink probe here is a little sector probe. It sends out a pie-shaped beam of sound energy that you can see when you look on the screen. This one over here, this green one, is a large footprint probe, okay? And this one here might be one that you would want to use for a large dog abdomen, okay? This one's kind of in the middle. So it has a sector appearance or a pie-shaped appearance, but on the other hand, it's got a little more of a linear probe, and it gives you really good resolution. And again, by looking at any of these, I can't tell you if these are low frequency probes or high frequency probes. Okay, what's inside these probes? Well, let me back up. I'm going to say a couple of things here. One is, why would, in general, a low frequency probe with ultrasound is anything probably 4 megahertz or below or lower. That's a low frequency probe. A high frequency probe with ultrasound is going to be any probe that's probably 10 megahertz or higher. Okay. And then the other ones are obviously in the middle. So why would you want to use a low frequency probe versus a high frequency probe, knowing the little things that I already told you about frequency and image resolution? Very good. Well, the reason being is if you're doing a cat or a chihuahua, would you want to use a high frequency probe or a low frequency probe?
High frequency.
High frequency, because you don't have much animal to penetrate through. The high frequency is always going to give you the best resolution. Okay, so it gives you the prettiest picture. So you would ideally, in the ideal world, which none of us live in, but ideally you would like to use the highest frequency probe for every ultrasound machine, every ultrasound exam that you do, because it gives you the best picture. On the other hand, if I try to use a 14 megahertz probe and do a St. Bernard abdomen with it, that 14 megahertz probe, the trade-off, even though the picture is good, it won't penetrate very far in the dog. And so you might only see the top 4 or 5 centimeters of the dog, and the rest you can't even see at all. And so some of those dogs, you would, by default, you have to use a lower frequency probe because they're bigger and thicker, and you got to penetrate that amount of tissue. The trade-off is the picture is not going to be as good. Okay, and there's no real way around that trade-off.
Are there specific cutoffs for when you would use each probe, or is that just kind of personal skill and learning through experience?
Personal skill and learning, that's a really good question, Kyle, but it's personal skill and learning and trial and error. So a lot of times, you know, if you have a big dog and you're trying to scan their abdomen, a lot of times I'll start off with a higher frequency probe, and if I just can't penetrate enough, then I'll switch to the lower frequency probe. And having said that, there's also ways to cheat. Okay, so if you have a dog lying on the table and you're ultrasounding it, one way to cheat the system is you can press down really hard on the abdomen. And that way, if you press down hard, you might have a kidney that's this deep. And if you press down hard, now the kidney's this deep. And now you can use a lower or higher frequency probe because you don't have as much tissue in the way. Okay, so there's, and when you get out and you start ultrasounding, there's, you know, don't be afraid to push down really hard. Most of the dogs don't seem to care. And you know that when by pushing down and putting firm pressure on the dog, you get closer to the organ that you're trying to see, so you can see a prettier picture in a higher frequency probe, and it also moves gas-filled bowel loops out of the way. Okay, the other thing I should probably say here that I'll say more coming up is ultrasound does not penetrate through gas. Okay, it can't penetrate through gas or bone or metal. All of those are super strong reflectors. And so if ultrasound propagates through the abdomen, it's going through your abdomen, and it sees a gas-filled bowel loop or the stomach that's got a bunch of gas in it, it will reflect 100% of that sound back to the probe, and you can't see anything in the stomach at all that's full of gas. And so that should tell you that in general, you can't use ultrasound to diagnose things that are in the lung, okay? Because the lung is full of gas. Ultrasound is pretty worthless as far as looking in the lung. The only time the ultrasound can be useful to look at the lung is if you have a mass or nodule and it's actually right next to the surface of the lung, and then you can see it because now there's no air at all between the probe and the nodule, okay? And so ultrasound sometimes will have very limited ability if you have a really gassy dog. So he's got a lot of air in his stomach and small bowel. A lot of times ultrasound, you really can't see much because of all the gas, okay? So what's inside one of these probes that makes it work? And this is kind of interesting, and I'm a nerd, so I kind of think it's interesting, but you know, y'all are kind of nerds too, or you wouldn't be sitting where you're sitting. Okay, so if you look at this, here we have an ultrasound probe. So it's got this cord that goes back and connects into the ultrasound machine, and the cord supplies power to the probe, and it also takes the data in and out of the probe back to the machine. Okay, around the ultrasound probe is usually this thick plastic housing that's there to give you something to hold, plus it's a protective mechanism for the probe. Okay, on the opposite end of the probe where the cord is, then you usually have what's called the window. And this is the very thin, very delicate portion of the probe that you don't want to drop. You don't want it to drop and land on this or stick a needle in this part or anything like that. Okay. So this has this plastic housing and then the thin portion. If I go back to these slides, here's the plastic housing, here's the cord, and this gray area is a very thin band of rubber. It's kind of like a rubber band kind of stuff. And it's very thin, and this part here is delicate. You don't want to drop it on that. You don't want to stick a needle in that. You want to be very careful with that. When you transport these probes, people will put them in protective devices that are around them, like I've seen people use a sock they put around, or they go buy some of that insulation you'd put around a pipe to keep it from freezing that you would get at Home Depot and cut it, and you can wrap these in that. Okay, anything to protect them. Okay, so it has this little thin window. Okay. The other thing that you look at it, this red wire is the electric wire coming into the probe. Okay. One side of this red wire is positively charged. The other side is negatively charged. And the wire terminates on these little black lines. Okay. And these little black lines represent an electrode, which means it's a piece of aluminum foil. Okay. So you have this very thin metal plate, if you will, or metal aluminum foil type thing that is on either side of this white thing. This white thing in the middle is the ultrasound crystal, or that's the thing that generates sound. Okay. And so on either side of this crystal, we have a positively charged metal plate and a negatively charged metal plate. Behind all of that is this thing called the backing material. And this is usually made out of cork or rubber or something. And the function of this, as when this generates sound waves, if the sound waves come back this way, this will absorb all that sound and make it go away. Okay, so that way the only sound that is allowed to exit the probe is going forward through this window. So let's take a little closer look at this area on this next slide. That crystal element, or the white part right in here, is made out of this stuff called lead zirconate titanate, kind of a fancy party kind of word. Okay. And the lead zirconate titanate has specific properties that you may or may not remember from physics, and they have what's called piezoelectric properties. Okay. And when something has a piezoelectric property, that means if I would push on it with my finger, so I would push on it and try to indent it. So I'm putting pressure on that stuff that has piezoelectric properties. The pressure that I would impart on that structure, then that structure would discharge an electric pulse. Okay, so something that is piezoelectric, it generates an electric pulse or electricity when things put pressure on it, physical pressure on it. On the other hand, is the opposite is true too. If I would shoot an electric pulse into something that has piezoelectric properties, it makes it change physical shape. Okay. The example of this is if you go down a road, not in Cayman probably, but anywhere else in the world, okay, you would go down a road, and if you should come up to an intersection and you're driving in your car, a lot of times you'll see these little cutouts. And somebody went and made a little cut in the road, and then that goes off to the side. And then if you look real closely off on one corner of these intersections, you're going to see a little metallic box that inside of it, there's a computer. Okay. And what they did is all of these little cutouts, they buried a wire inside here and then covered up with this gray plastic stuff. Okay. Well, that wire that is in there has piezoelectric properties, because we all know the function of these things is when a car comes up here up to the intersection and stops, the weight of the car will run over these wires, And because those wires have piezoelectric properties, as soon as I have the car weight on one of these, it generates an electric pulse that goes over to that computer in the corner and says, there's a car here, we need to turn the light. And there's usually one or more of these things back here. So if the traffic starts to back up, it knows not only is there a car here, but now there's a bunch of cars here. And when I turn on the light, I need to leave the light on longer, so I can let all of those cars go through. That's the general, that's how it was supposed to work until it breaks, okay? So that's a real world example of something that has piezoelectric properties. And I think that helps to explain it. Well, with ultrasound probes, it's basically the same thing. So I have this crystal inside the ultrasound probe, and inside that crystal, it's made, again, of this stuff called lead zirconate titanate. And each one of those little individual crystals inside there have a plus and a minus pole, so a positive and negative pole, that all together, they're all kind of aligned the same way, okay? And if you look, here's our electrodes coming into this crystal. And so right now, this doesn't have a positive or negative charge. It's neutral, it's just sitting there. And as such, the crystal is shaped like this, and it's that long. Okay, but because this lead zirconate titanate stuff has piezoelectric properties, as soon as I put an electric pulse on it now, what happens to the size and shape of that crystal? It changes. So if you look in B here, when it's energized, all of these individual crystals, they're now all aligned, they're parallel to each other, and in group, it caused this crystal to become longer and skinnier, okay, than it was when it wasn't energized. So what would happen now if I alternate this? So if I turn this on and off, let's say 60 times a second, what's the crystal gonna do? It's gonna change shape 60 times a second, okay? It's gonna go back and forth and change shape. And as it changes shape, it generates a sound wave in front of it, just like the speaker coming in and out, okay? So as that lead zirconate titanate crystal, if you pulse electricity and you turn it on and off multiple times per second, then it changes shape and it moves in and out just like this speaker and generates a compressional wave in front of it. That makes sense, kind of? Okay, so so now we've talked about crystals, we've talked a little bit about physics and things, and now we have to talk about, once we have the sound generated by the ultrasound probe or transducer, that sound wave then goes into our bodies. And when it goes into the bodies, it interacts with soft tissues and bone and air and everything else. Well, basically there's three types of interaction that the sound waves can go and have when they enter into our body. Okay, the three things that can happen, the sound can be reflected off of things, and that's what we use to make a picture of. That's the only useful part of the ultrasound, is if it reflects off the edge of your kidney or a bladder stone or the edge of the bladder wall or whatever. Okay, so that's the stuff we count on. So it's sound that comes out of the probe, it goes into the bladder, it sees a stone in the bladder, the sound reflects off the bladder wall and the stone. That reflected sound then travels back through the tissues, back to the ultrasound probe, which is listening 99% of the time. And then it takes that information and makes a picture of it inside the ultrasound computer. Got it? Okay, so reflected sound is useful. The other way that sound interacts with matter is it's absorbed or attenuated. Okay, and so in this particular case, as the sound travels through the tissue, some of that sound is actually absorbed by the tissue. There's conservation of energy, and so that sound is actually converted into heat, okay? So that sound isn't useful. It's absorbed by the tissues, and it causes minuscule elevation in tissue just for an instant into those tissues, okay? So that's absorbed sound or attenuated sound. The bigger the tissue mass is, so a big dog abdomen, as your sound propagates deeper and deeper into the abdomen, there's more and more sound that's attenuated or absorbed and used up. And obviously, the more sound that's attenuated or absorbed by the tissues, then there's less sound to make a picture out of, okay? So absorbed sound or attenuated sound does nothing for us. In fact, over time, and the further deep you get into the tissues, it degrades picture quality. The third type of sound is refracted, and this is also not useful. We'll talk about it here in a minute when we talk about a certain artifact. So this is actually where sound changes, the wavelength of the sound changes as it goes from one type of tissue to another type, okay? We'll talk about that here in a second. Okay, so we said the only type of sound that we use diagnostically is reflected sound. So it's sound that comes out of the probe and reflects off the surface of something, and then goes, that sound, that reflected sound then goes back to the probe, and we take a picture of it. There's two types of reflected sound to get things a little more deep. Basically, you don't need to know this. I don't care if you know it's called specular or diffuse reflection. Basically, the concept that I want to say for you to understand, let's say this black line here is the edge, the capsule of a kidney. Okay, so this is a capsule of a kidney, and we all know from anatomy, or if you post a dog or whatever, if you open the dog up and you look at the kidney, what is the capsule of the kidney going to look like in a normal dog? In a normal dog, it's kind of have this white sheen to it. It's very smooth, it's glistening, and it's smooth, and it looks like this black line. So it's a smooth surface. Okay, if I have sound that's incoming, these blue arrows, and it hits a smooth surface like the capsule of a normal kidney, we can predict by looking at the angle that it hits that surface, we can accurately predict, probably there's some mathematical formula to predict the angle of which the sound is going to bounce off that surface and reflect in another direction. It's kind of like shooting pool. Okay, if I shoot my cue ball down here and it bounces off the bumper, depending on the angle I shoot it, it's going to vary the angle that comes off that edge of the pool table, right? On the other hand, if I look at this surface over here, instead of this kidney being nice and smoothly marginated, this is a cat with chronic renal disease. And we said radiographically, cats with chronic renal disease, their kidneys become small and very misshapen. Okay, so now we have the edge of this kidney that's very irregular in shape. So now when I shoot my same cue ball or my volley of sound, now I can't predict that all of the sound is going to go off in the same direction. Some of it, depending on what angle it hits of this rough surface, some of it may go off in any direction, basically any way. And that leaves less sound to reflect back the right way. So the bottom line with this is if I'm ultrasounding something with a smooth surface, by the time the sound reflects back to the probe, I see a nice, very smooth, very thin, smooth surface on my picture. On the other hand, if I have a cat with chronic renal disease and the surface of the kidney is very irregular and lumpy bumpy, the picture that I get, because I have less sound that reflected back, is going to be ugly. It's going to be thick-walled, kind of poorly defined, and it's going to be much uglier and less crisp. The resolution's not going to be there. And that's because of the surface is roughened in appearance and sound bouncing off in every direction. Okay, the other thing that we'll talk about is the Doppler effect. And everybody probably heard the word Doppler before from physics. The best example of the Doppler effect is, let's imagine that you are, I don't know why you would do this, but let's imagine that you're sitting, you pull out a chair, and a lawn chair, and you go sit next to the railroad tracks. So you're 10 feet away from a railroad track because you're doing this because it's a nice day and you're 6 feet, you're social distancing from everybody, right? And it's a nice day and you happen to like trains, okay? So, I mean, it's gonna make your day when the train comes by, okay? And what you're doing is you get all excited and you're sitting in your chair with your beverage and you see way down the track, you see this train starting to come and your heart rate starts racing and you're saying, man, I waited all day for this. The train's finally coming, because you have this weird thing for trains, okay? And as you see that train, you stand up and you stand next to your chair, and the only other thing that is gonna excite you more than the train coming your way is if that train was blowing its whistle. Okay, and so you sit and you're standing next to your chair and you see the train coming, and what do? Right? Because you want to hear, yeah, exactly, Ethan. You stand there and you start doing this. I mean, you're doing this and you're saying, come on, pull your train whistle, turn your whistle on, right? And so the engineer in the train finally sees you and he wants to accommodate you. And so sure enough, he's pulling the train whistle. As that train comes by you, whistle blowing, what are you going to hear? you're going to hear the train whistle, obviously, but at right the instant that train passes by you, and don't make fun of me here, but as that train passes by you, you're going to hear choo choo like that. As soon as it passes by you, the pitch of that train whistle will decrease. Okay. That's the Doppler effect. Okay. And so, and there's different things that will vary the change in pitch. Okay. One of the biggest things that will vary it is how fast the train's going. The faster the train goes, the greater pitch change that's going to happen. So it's going to go from a higher pitch down to a much lower pitch. And it's intuitive. You know that. Okay. If the train was barely going, you wouldn't experience a Doppler effect at all. Even if he's blowing his whistle, it would stay the same. But the faster that train goes, the more Doppler effect is going to happen. Okay. That's one of the biggest things is the velocity of whatever the train moving will vary the amount of Doppler effect. Well, now there's an equation that you might have used in physics, I don't know, that you can predict the amount of the Doppler effect. And if we rearrange that equation like it is in this form right in here, okay, if we look at the angle of incidence, so if we're ultrasounding something and we look at the angle of incidence, then we can actually calculate how fast the train is going by using the Doppler equation. Now, what the hell does this have to do with ambulances and trains and whistles and train fetishes, okay, with anything with ultrasound, okay? Well, it has a lot to do with it because the Doppler thing happens in ultrasound, except for trains. We don't have trains in our body, but we do have tracts called blood vessels. And inside those tracts, we have miniature moving trains called red blood cells. Okay. And so if we have our ultrasound probe here and we know this angle, which we can calculate from the ultrasound machine, and we turn on the Doppler, we can actually calculate how fast the blood is flowing inside that vessel. That's pretty cool. That's how Doppler is used in ultrasound. And then the other thing that you might remember, so I don't think that works, but here, I'll back up here. The other thing that you might remember here in a minute, not only can we calculate how fast the blood cells are moving, but if we use another equation that we'll talk about in a minute called the Bernoulli equation, then we can convert velocity into pressure. So then we can also calculate not only how fast the blood is moving, but what's the blood pressure inside there. So we get lots of information from the Doppler effect. And it all starts with your fetish for a train. Okay. So here's the Doppler effect. So right in here, if you look at this animation right in the middle, this little dot in the middle is your ultrasound probe. And it's sending out sound waves or volleys of sound in every direction away from it. Okay. Right now, the ultrasound probe or the train, right, is not moving. And because it's not moving and it sends out these concentric rings and all of them have the exact same distance apart from each other. On the other hand, if I start to move the train and I still send out these waves, in front of the direction, in the direction of the train as it's moving, the waves now are compressed. They're closer together than they are if they look at the distance between the waves behind the train, right? And this is what's causing the Doppler effect. So now I have a train that's moving at the speed of sound. And so now there's nothing, there's no sound wave at all in front of that moving train. Okay. Eventually, if the train goes so fast and it goes faster than the speed of sound, then you won't hear sound until after the train is gone by you. The better analogy here is an airplane. Okay. So this is an airplane moving at the speed of sound, which is otherwise known as what? Mach 1, right? And so this is an airplane like a fighter jet and it hits Mach 1. As soon, if you're standing right here, right where the tip of my arrow is, you're going to hear nothing until right when that airplane gets right above you, and you're going to hear this boom. That's the sonic boom people used to wonder about, and how did it generate that? And that's because the train is going at the speed of sound, and I don't hear any sound at all until right when it gets to you, and boom, there I hear the sound. That's a sonic boom. If we speed up that airplane and now it's going faster than the speed of sound, like Mach 2 or 1.5 or Mach 3, whatever, you don't have a sonic boom anymore. and you won't even hear anything until you hear this gradual crescendo of sound after the plane has actually passed by you. Okay. So there's a picture, I don't know if this is photoshopped or not, but it looks pretty cool, of a fighter jet right when it hits Mach 1, and it will generate this cloud right when it hits Mach 1. And that's this disruption of sound waves of energy that's coming off right when the plane crosses Mach 1, or the speed of sound. Okay, so again, what is the significance of this whole Doppler thing when it comes to ultrasound? Again, we can predict, number one, several things with Doppler. Okay, number one, we can predict, is there blood flow in a vessel? Okay, if we have our calculations right and we have the machine, we can also predict not only is there flow, what's the velocity of the flow? Okay, and then if we have another thing called color flow Doppler, not only can we predict is there flow, how fast the flow is, but we can predict what direction the flow is. Is it coming towards a probe or away from the probe? And I'll show you that in a minute. And the fourth thing, by using this Bernoulli equation, now that we know the velocity, the Bernoulli equation says the change in pressure equals 4 times the velocity squared. So by using the velocity that we got from the Doppler, we plug it into this equation, now we can predict pressure. So it gives us all kinds of information that's very useful, and it's non-invasive. We're not cutting anything open. By using the Doppler information, then they also came up with color flow Doppler. And almost all machines nowadays have it. Sometimes you have to pay extra for it, but they all have it. Okay, so there's, again, to complicate things, there's two basic kinds of color flow Doppler. Most of the time you're gonna see this standard color flow Doppler, and it looks like this, okay? So you have reds and blues, okay? And the thing to remember with color flow Doppler is by looking at the color of these blood vessels, this is liver and this is blood vessel flow. So that's number one, is does it have color? If it has color, there is flow inside that vessel by definition, okay? But if I look at the color of those vessels, of the flow inside the vessels, that can tell me which direction the blood is flowing. And the acronym that you need to remember is BART, like as in Bart Simpson. Okay, and BART stands for blue away, red towards. You probably should know that. Okay, so that means here's the surface of the probe. This is the near field right up in here. This is the far field. Notice in the near field you can see stuff. In the far field it starts to go away because the sound has been absorbed or attenuated the further it gets from the probe surface, right? And so if I'm looking at this near field, here's the probe surface right in here. I send sound out. If you remember blue away, red towards, well, here's a blood vessel right in here. We know it has flow because it has color, but what color is it? It's red, red towards. So the flow in this vessel is going up here towards the probe. So it's going from bottom up. This vessel here, for the most part, is blue, okay? And so blue away. So what direction of flow is in that blue vessel? It's going away from the probe. So it's, in this case, it's going from the top down. Okay, so that's how we use color flow Doppler to determine the direction of flow. The other type of Doppler is called power Doppler. Okay, one of the problems with standard color flow Doppler is that if the flow of fluid and red blood cells in that vessel becomes really low velocity, just like the train going by you, we don't get much of a Doppler effect. Okay, the faster it's going, we get better color flow. Okay, well, there's certain things in our bodies that we would like to see if there's blood flow in it, but the flow is so slow, it's hard to see with standard color flow. So they came up with this other type of Doppler called power Doppler. And power Doppler shows slow flow, okay? Almost down to the perfusion level of cells, okay? But the trade-off with power Doppler, you notice there's no reds or blues. Okay, power Doppler does not show you the direction of flow. It just says, is there flow? Okay, but it's useful to be able to look at structures and see, is there flow? Is there really slow flow in those structures? And actually people can use this sometimes to look at nodules or masses that you'll see inside the liver or the spleen and see, is there blood flow? And look at the pattern of flow, and that might help you to predict if that's something benign or malignant. Okay. So it's break time. So we're going to start off right there after a 10-minute break. Is everybody cool? Okay, get your lawn chairs out, get ready for the trains, go outside. We got 1 more hour and then you can go sit out there. All right, I'll see you in 10 minutes. Oh, okay, is everybody there? Okay, can you see this slide? We're cooking with gas still, that's good. Okay, so any questions about what we went over in the first hour? Physics, trains, fetishes, all that stuff. Everybody good with that? Okay. Okay, so now we need to talk, get everybody on the same page, a little bit of vocabulary. This stuff's easy. So the word hyperechoic, again, we're all doctors here and we learned how to take words apart to figure out what they mean, right? So what does hyperechoic mean? It means with more echoes than normal. So things that are hyperechoic are things that show up really bright or kind of white on the ultrasound machine screen. The opposite of hyperechoic is hypoechoic. Okay. Hypoechoic things are things that have increased darkness because they have too few echoes. Okay, so they show up darker. Anechoic means literally without echoes. Okay, so things that are anechoic show up pure black on the ultrasound machine. They generate no echoes at all. Okay, isoechoic is a relative term that you use to compare one structure that sits right next to another structure. If they have the same shade of gray, if you will, then those two structures are isoechoic to each other. They're the same level of gray, same shade. Okay. So what's some examples of these that you could use? Something that is hyperechoic. You're going to learn here real soon that the spleen normally is more hyperechoic or it's brighter in appearance than the liver. And we're going to talk about that, but that's how you would use that term. On the other hand, the inverse is true. The liver typically is more dark than the spleen, so it is more hypoechoic than the spleen. If the liver and spleen are exactly the same shade of gray, then we say they are isoechoic to each other, right? And tell me something that would be anechoic with ultrasound. Well, that's easy. Anything that is full of pure fluid that has no cells in it shows up black. The blacker stuff shows up on ultrasound, the more fluidy, if that's a word, the more fluidy it is. Okay, so typically in a normal dog or cat, the urinary bladder is full of urine, which typically normally does not have cells or anything floating in it. And so urine in a normal animal shows up anechoic, it's totally black. On the other hand, if I stick red blood cells in it and I slosh it around and move it around, or if they got an infection, then I'm going to see cellular debris floating around inside the urinary bladder. So no longer is it anechoic. Okay. The near field, we kind of talked about that. So the near field is the portion of the image that's closest to the skin surface where you're touching the dog with the probe. The far field is the portion of the image that's furthest away from the probe. So what about ultrasound? What's some statements, general statements that it can and cannot do? Well, ultrasound is really good at looking for inside of the organs. We talked about radiographically. Radiographs are better for looking at the size and shape and margination of the organs, but not so good for looking inside the organ. Like most imaging modalities, including MR, ultrasound is highly sensitive, but it's also highly non-specific. And so what do I mean by that? That means if I'm ultrasounding a dog's liver and I see 3 nodules and they range, they're 3 centimeter, 2 centimeter, and 1 centimeter in size, and they're well defined, I could describe the heck out of those nodules. I can tell you everything about them. They're well defined, they're exact measurements. The center of them is mixed in echogenicity. I can tell you everything about them, but have I told you what they are? No. And so highly sensitive means you can describe the hell out of them, but I still don't know what they are. And the only way to know to make the specificity goes up and get a confirmed diagnosis is, in general, you have to do what? You have to aspirate them and look at those cells under a microscope. Okay. And you can use ultrasound guidance to get good at that. And you can stick anything that's probably 3 millimeters or less in diameter. Okay. If you have ultrasound and you know how to use it, it will allow you to diagnose more pathology. Obviously, if you have a mass inside the liver, but it's not bulging the capsular surface yet, you won't see that mass with radiographs. However, if you have an ultrasound machine, you can see the mass. So it will allow you to diagnose more pathology than if you don't have ultrasound. It's really good for focal or multifocal disease. So what do I mean by that? That means if I have discrete mass lesions inside the liver, then I can see them and they're easy to spot. I can describe the heck out of them. On the other hand, if I have a certain disease process that affects the liver, the entire liver, exactly the same way, okay, it may cause the liver to be slightly more hyperechoic than normal, or slightly more hypoechoic than normal, or slightly rough or coarse in architecture, but that's harder to pick up than a discrete, well-defined mass. Okay, some examples of diseases that can affect the liver like that diffusely and very, to where you can't really recognize it would be lymphoma or mast cell disease. Sometimes the liver looks essentially normal. Okay, and the other thing about ultrasound is it's kind of fun to do until you've done a million of them like I have, and then it's not very fun anymore. Okay, so what can ultrasound not do for you, on the other hand? So just because you go buy an ultrasound machine doesn't make you a better diagnostician, a better doctor, and it doesn't allow you to use more pathology if you have the machine sitting in the corner of your room. You have to take the time and know how to use it, okay? Ultrasound, like any imaging modality, will not differentiate benign versus malignant disease. Okay, I can have a splenic hemangiosarcoma, it's nasty, cavitary, big mass in the spleen, got septations all in it. It's ugly. But an ultrasound of the spleen hemangiosarcoma appearance looks just like the ultrasound of the spleen that looks like a big hematoma. Okay, so by looking at it, I can't tell you if something's malignant or not malignant, and you have to get cells out of it and look at those cells with histology under a microscope or cytology. Also, just because you're fluent and have a good ultrasound machine and you know how to use it doesn't mean you're never going to take radiographs again. In fact, in my book and most people's books, you're probably going to start with radiographs in almost every case. And if you can't get the information you need off radiographs, then you go to ultrasound. Okay. And just also from we said from the last slide, when I talked about diffuse involvement of the liver with mast cell disease or lymphoma, just because an organ looks normal doesn't mean it is. Okay, so you can have certain diffuse diseases like mast cell disease or lymphoma in a liver or spleen, and it looks sonographically normal. You also have certain nodules. I remember this when I was in practice in the referral clinic, is that sometimes, there's this healthy confrontation fight always between radiologists and surgeons. In fact, as you get out, the surgeons like to fight with everybody because they're egotistical maniacs, right? And so that's just a surgeon. And so there was always this healthy back and forth, and I think it's everywhere in medicine between radiologists and surgeons. So every now and then, I always knew I screwed up if the surgeons would be cutting some dog, and one of the techs would walk in and they say, "Dr. Poteet, Dr. Liska needs your help in surgery. He doesn't need my help. He wants me to come in there so he can say I was wrong." Okay. And so I remember several times things that would happen, and I realized before long, I ultrasound a dog, his liver looks fine. You go to surgery and they cut the dog open and there's nodules on the liver surface that you can see. And how do you explain that? And that's because if the nodule doesn't have difference of acoustic impedance than the surrounding liver around it, you're not going to see it with ultrasound. So like any imaging modality, ultrasound isn't perfect. Okay, is not going to show every pathology every time. Okay, and then I got to where I would tell the surgeons at that time, I got so pissed off, I would just say, the big difference between you as a surgeon and me as a radiologist is I can admit I'm wrong every now and then. Okay, which is true. Okay, so ultrasound cannot rule out the presence of disease. Scanning tips before you go scan. Here's what you need to do, and I'll give you couple other pointers too. One is, and this is hard to say, proper patient preparation is essential. Okay, and what do I mean by that? That means ultrasound does not penetrate through hair because hair traps gas. Okay, and ultrasound doesn't penetrate through gas. So every time you ultrasound a dog's heart or his abdomen, you have to clip the hair like you're going to do surgery. So down to the skin surface, you have to clip the hair and shave the hair. Every now and then you're going to get some owner that says, you can do the ultrasound, but you can't clip the hair. And that's when you tell the owner, well, then you need to go somewhere else to do the ultrasound, because if you do the ultrasound, you're going to get artifacts and misdiagnose things. Okay, so you have to clip the hair. Okay. The other thing that you want to do is you always have to use ultrasound lube or gel or whatever you want to call it. Okay. And most of the time you buy this commercially, it comes in big gallon jugs, and then you can refill the little catch-it bottles with it. Okay. So you have to use some type of gel, and that allows the sound to penetrate from the probe and into the body. Okay. You can use water, you can use alcohol, but water and alcohol evaporate real quick. And so you're constantly having to reapply it. And that's where ultrasound gel comes in. Knobology, that's the study of knobs, right? And so you have to know how to work the machine. You have to know what some of the knobs do. There's some knobs on the ultrasound machine, once you set it, you'll never bother with those knobs again. But other ones, like the gain and the depth and things like that, you're going to be constantly fiddling with while you do the ultrasound. So you have to know what those knobs do. You have to orient yourself with the probe and the image, which sounds a little strange, but you do. You have to orient it to where when you're looking at the screen of the ultrasound image, you have to know which way is cranial and which way is caudal. Now, when we talked about radiographs, remember there was a hanging protocol, right? And so with a lateral view of the chest or the abdomen or a stifle joint or the pelvis, which way did we always place cranial? To the left. Remember? So with ultrasound, why screw things up? Let's just do the same thing. Okay. So every ultrasound image that I'm going to show you of the abdomen heads to the left. That makes sense, right? So that we just keep it that way. Okay. When people do echoes, the echoes are usually done by the cardiologists, which are internal medicine folks, and they do most of the echoes, and they have to flip the dog around. So when you're looking at echoes, heads to the right. The rest of the imaging world does it with the head to the left. Why they had to flip it the wrong way, I don't know, but they do. So in general, head is always to the left, just like it is with x-rays. The other thing that I always tell people is you need to scan the entire cavity, okay? With rare exceptions, okay, do you want to just only scan like the bladder? You always want to do the whole animal. And I think this has to do with, we're veterinarians, we have patients that can't talk to us. They can't tell you where in the abdomen they hurt. And so I think it's doing justice to get in the habit of, let's just do a complete ultrasound of the abdomen every time you do an ultrasound. Even if you're only looking for bladder stones, let's go ahead and look at the liver and the gallbladder and the spleen, because you might find something, and a lot of times you do. Okay. The other thing that I would tell you too is be systematic. Do every ultrasound procedure that you do in the same way. So everybody has a routine that they do. I tend to start off in the urinary bladder because it's easy to find. And when I didn't know what I was doing, it filled me with confidence to know I found the bladder. Okay. So I start off in the bladder, and then I come up the left side of the dog's abdomen. So I look at the bladder, then I look at the spleen and the left kidney and the left adrenal gland. Then I come cranial, I look at the left side of the liver, the mid portion of the liver. Then I start to come to the right side. Then I look at the right side of the liver and the gallbladder. And then I start coming back down the abdomen caudally. So then I look at the right kidney and the right adrenal gland. And then I kind of fan through all the middle to look for everything else, like bowel and stomach and pancreas and stuff like that. But that's my routine. Doesn't mean it's the only way to do it. Doesn't even mean it's the right way to do it. But that's how I do it. And that's what you need to do, is be systematic, figure out your way, and do it that way every time. And again, we kind of mentioned this earlier, there's a way to get your big dog abdomen that's that deep, and you cheat if you push down, and now you can use the higher frequency probe because now the abdomen's only that deep. Okay, so don't be afraid to apply firm pressure when you're doing the ultrasound. And when in doubt, stick it. So if you see something that looks abnormal, plan on putting a needle in it and getting cells out of it and look at those cells under the microscope. There's only really one thing I think that's in the abdomen of dogs that people generally do not stick, and that's the adrenal glands. Everything else should be fair game. Okay, artifacts. There's some artifacts that you have to know with ultrasound because, and the weird thing, unlike radiographic artifacts, there are some artifacts with ultrasound that actually help you make a diagnosis. Okay, there's other ones that actually hinder you to make a diagnosis, but some of them actually help you. So let's talk about some of these basic artifacts that you need to know. Okay, so the first artifact is just you get a crappy image. Okay, poor image quality, and there's several things that can cause the image to look piss poor. Okay, the biggest one is back to you have improper patient preparation. So you didn't clip the hair, you didn't clip the hair close enough to the skin surface, you didn't put your ultrasound gel on. Those are all things that will contribute to poor image quality. If you have a really fat dog, okay, that's going to have really great radiographs, but again, fat gets in the way with ultrasound. And so the fatter the dog, the uglier the image is going to appear with ultrasound. Some dogs come in and they have chronic skin problems. They have really thick skin, or like in Shar-Peis, where it doesn't matter if you clip them down to the skin, they still have stubble. Okay, and that traps air. And so sometimes chronic skin and dogs with stubbly skin and stuff like that, your ultrasound image isn't going to be the best. When in doubt, if your image starts to get poor, put more gel on it. That's a good thing. And you have to remember, again, gassy animals are not going to have really good ultrasounds because they have so much gas. So ultrasound, again, cannot be used in general to visualize things in the lung unless they're right adjacent to the surface of the lung. Or if your machine is all screwed up. Okay, it's not set up properly. The gain's turned so far down, everything looks black, or so far up that everything looks white. So here is a crappy image, okay? In the middle here, this is part of the left kidney. But if I didn't have this here and I told you, what is that? You're gonna go, I don't know. It looks like, I can't tell what it is. It looks like there's something round or oval, but I don't know what it is. It could be a mass. In this case, it's the left kidney, and it's just a poor quality image. So then you go back to that list we just saw before and figure out, well, are any of these taken a part of this and causing this image to appear poor quality. When in doubt, again, put gel on it. Okay, most of the ultrasound places that you're going to go and you're going to end up in, you buy gel. You'll have some of these ketchup bottle like things, and that's what you use when you ultrasound the dog. But you refill these little ketchup bottles with gallon jugs of gel. And this stuff's pretty cheap, and you can buy it as a case, and it comes with 4 gallons in it that you use to refill these little ketchup bottles. Okay, another ultrasound artifact is called posterior shadowing. And this is an artifact that actually helps you make a diagnosis. So what is this? We're just going to look at a picture because I'm kind of a picture kind of guy, right? So if I look at this structure here, this is the urinary bladder right in here. And the bladder is filled with this anechoic fluid. And then I have this thing sitting inside the bladder. Okay, that's a stone that sits inside the urinary bladder. Okay, this stone is made out of some type of mineral composition, calcium oxalate, something that is rock-like, mineral bone-like, right? And so what happens with this stone, we mentioned that when we have ultrasound and the ultrasound probe is up here, it sends out a volley of sound that comes down this way. Okay, does ultrasound penetrate through stone or metal or gas? No, it doesn't. It causes 100% of the sound to be reflected. So if I'm an ultrasound, if I'm riding on one of these ultrasound waves, I come down here and I see this thing that's not fluid filled, but it's a stone, okay? I'm gonna reflect 100% of the sound is gonna reflect off that structure, that bladder stone, and go back towards the probe, which generates this big, really crisp, white, distinct line, okay, that marks a stone. But because I have had 100% of the sound reflect back towards the probe, what percent of the sound goes further? 0. And so it causes a shadow. Okay, that's called posterior shadowing. Okay, and posterior shadowing will help you define a stone in the urinary bladder. Now, let me ask you this. I'm going to make you use your noodle here for a second. Okay, that's a stone. It could be two other things inside there that we just mentioned that could also cause posterior shadowing artifacts. Doesn't have to be a stone. What's another one? If it's metal, okay? What's another one? If it's gas, gas will do the same thing, okay? Now, let's look at the odds of this. Number one is if it's metal, what are the odds of you having somebody shot your dog and you have a bullet in your bladder? Probably not very good odds. And so if you had to bet between a stone in the bladder or a bullet in the bladder, I would probably bet on the stone every time, okay? Now, what about gas? How would you differentiate this stone versus gas? Well, if it's gas, it's going to float. It's going to be up here instead of down here. Okay, that's how you would differentiate it. So posterior shadowing is an artifact that is useful to us because it helps you define typically a stone that's somewhere in the abdomen, bladder, in the liver, somewhere. Reverberation artifact is another one. This one just gets in the way. It doesn't really help us much. Okay. Let's say, in trying to explain the reverberation artifact, let's explain that away. Here's our transducer right in here at time 1. And that transducer is going to send out a volley of sound, which is represented by these arrows. And the length of time the sound is permitted to be on, or how thick the volley of sound is represented by the length of these arrows. Okay, when this transducer generates that volley of sound, over time, that volley of sound is going to move from left to right. Okay, as it moves from left to right, it's going to see two interfaces. So let's pretend this is the edge of the bladder and this is the edge of the colon. Okay, so as that sound moves towards interface A, right in here, a portion of the sound is going to hit interface A and reflect back towards the probe. So it's making this little turnaround, 180-degree turnaround, and then it starts to reflect back the probe. And over time, it goes back to the probe and it makes a picture on your image. Okay, but another portion of that sound continues on. It didn't reflect off surface A, it goes to surface B, but then reflects off surface B, which then makes the 180-degree turnaround and trails the first echo as it goes back to the probe. So you end up with these sounds reflecting back to the probe, a blip on your screen here, followed by another blip here, and soon to be a third blip, and then maybe a fourth blip as sound tends to recycle between these two interfaces. Okay? And the result of that is you get lines, hyperechoic lines that are parallel here, 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 and here. That's called a reverberation artifact. And that's due to sound waves that are revolving inside a strong reflector. So usually in a bow loop that has just a little bit of gas in it. Okay. And it causes the main one here, that's the real art, that's the real tissue. But all of these are artifact due to a reverberation artifact. And the key is they're all the same distance apart. They all look just like each other. And the other key is the deeper and deeper and deeper you get into the tissues, they become less and less distinct. And that's because as this sound reflects and revolves back and forth inside of these tissues, every time it does that, there's less and less sound left to generate a picture. Okay, so that's a reverberation artifact. If that happens, if that reflector is so strong and it's so thin, then all of them are all compacted upon each other. And another type of reverberation artifact is called a comet tail artifact, because now they're so tight and so packed on top of each other, it causes this comet tail appearance, which is a type of reverberation artifact. And this you'll see very commonly in the stomach where there's gas. Okay, I can't tell you what's in the stomach, but it causes these artifacts. Okay. Slice thickness artifact. Realize that if I have an ultrasound probe here and it's sending out a fan-shaped volume of sound, okay, it has a certain length that it goes depth-wise into the tissues, but it also has a certain width. So this slice has a certain thickness, and let's say it's a millimeter thick. Okay, if I take that same slice, and if I was in person, I would have a better way to do this, but hang on, I'm going to get something that's a visual that might help us here. Okay. I have my book. So I'm going to use this book, which is everything you ever wanted to know about the Andy Griffith Show. Okay, it's a very good book, right? And we're going to use this book to demonstrate this artifact. Okay, so let's say that the thickness of the ultrasound, the sound wave itself coming out of the probe, is exactly as thick as this book is right there. Okay, and it's coming out at you, and it's going to go hit something inside the body that's round, like the picture here of the urinary bladder. Okay, so if I have a bladder that's sitting, oh wait, I got another visual. Here's a rock right here that one of my sons painted for me. Okay, there he signed it back on the back. So here's my round structure like a bladder. And I got a sound wave coming at, and it's going to come towards this rock right in here. What's going to happen? Well, it's the sound waves is going to split the rock like that. Okay, see that? And so I have some sound that's in the width of that sound wave that's going outside the rock. Okay, I have a little bit of sound, like these few pages right in here, that are going to actually see the wall of the rock, the edge of the rock, or the wall of the urinary bladder. And then I have some more sound, that's the thickness, that's going to go inside the lumen of the urinary bladder, right? And so I get a combination of sound waves that make a picture of what is outside the bladder, which is usually a little bit of mesenteric fat. I get a picture that contains the bladder wall itself, the little bit in the middle, right? And then I get also a picture that is inside the bladder, which is usually anechoic fluid like urine. All of those sounds reflect back to the ultrasound machine, and the ultrasound machine makes a picture that's a combination of all three. And that's due to slice thickness. It has a finite thickness like Andy Griffith does, right? And so if I'm looking at that, here I have the urinary bladder. I can see black fluid inside the urinary bladder. So that's the part that went inside the bladder lumen, all of this, okay? I can see the edge of the bladder wall around it. So that's the little bit in the middle that went into the bladder wall. And then all of this stuff that went into the fat outside the bladder generates this artifact that's inside the bladder. And the picture is just a conglomerate, a mesh of all of those different acoustic structures that it sees, okay? And so the end result was slice thickness artifact, and typically you'll only see this for the most part in the region of the urinary bladder or gallbladder, something that's fluid and round. So I get a picture that looks like all three. I have anechoic fluid, I have bladder wall, and I have debris looking stuff inside the bladder. But I realized that that debris stuff inside the bladder, there's a good chance it's artifact, and it's caused by slice thickness artifact. So how do I differentiate? What do you do? How do you differentiate? Is this real inside the bladder? Could that be cellular debris or hemorrhage or something inside the bladder, or sand-like calculi? Or is it artifact? What can you do to help differentiate that? Very good. One thing that you can do is you can agitate the bladder. So your probe's sitting up here on the skin surface, and you shake the bladder up pretty vigorously. So you just shake it up and down, move it left and right, and then stop and look at the bladder. And if this stuff is floating debris, it's going to be swirling around like a snow globe. Okay, so that's one thing you can do. Another thing you can do is you can turn the dog, instead of him lying on his back in this case, you can turn the dog and let him stand up on all fours and ultrasound it from underneath. So you do it upside down. And so now you have a dog standing up, and if this was cellular debris, where's it going to move to? Now it's going to go down here to the ventral aspect. And the other thing you can do is you can, right now I have my probe in longitudinal axis. This is cranial on the left. This is caudal. I can turn my probe 90 degrees. And now I'm going axially through the dog, or a cross-sectional cut through the dog. If this is artifact, it's going to go off to the side. If it's real, it's going to stay in the urinary bladder. So those are some things that you can do to try to convince yourself, is that real inside the bladder, or is it slice thickness artifact? Okay, another one that we need to talk about is called the mirror image artifact. And this one you're only going to see in one particular spot, but it will screw you up, okay? And it's an interesting one. Here I'm looking at the edge, just to get your anatomy here, because y'all don't know yet. This white line right in here is the diaphragmatic margin. So that's where the diaphragm lives. Cranial is this way, caudal is this way. So right in here, I see there's the gallbladder, i.e. GB. There's the gallbladder. It's got some cellular debris in it, most likely. This is liver tissue right in here, okay? This is the diaphragm. What artifact is this right here? That's right. It's a reverberation artifact or a comet tail artifact coming off there. But also look at this image artifact right in here. Can you see on the other side of the diaphragm, it almost looks like there's gallbladder sitting here, just like over here. And in fact, what ended up happening in people when they started doing ultrasound medically in people, like in the 50s, is the radiologists were learning as they went, and they would ultrasound somebody's liver and diaphragm, and they would see this called the mirror image artifact. And it would look like they had a diaphragmatic hernia, that there's pieces of liver in the gallbladder that are cranial to the diaphragm. And if you go back and you look at the medical literature in that day, lots of people got cut for diaphragmatic hernias, and the surgeons went in there and their diaphragm was normal. Okay. And then they discovered, oh, well, that's an artifact. It's the mirror image artifact. Okay, so that will only happen typically on the edge of the liver near the diaphragm, where it looks like there may be gallbladder or liver on the other side of the diaphragm. And it's caused by the fact that over here, what is on the cranial aspect of the diaphragm anatomically? What lives there? Lung. Does ultrasound penetrate through lung? No. And so it doesn't. And so you have to look and make sure that all of this sound that hits the diaphragm is really hitting that side of the lung. And so all of that sound is reflected back. And as the sound travels back to the probe, it causes an artifact to make it look like the gallbladder is on the other side of the liver. Okay. Posterior enhancement. We talked about an artifact a minute ago called posterior what? Posterior shadowing is what we talked about before, right? Posterior enhancement is the opposite, okay? So posterior shadowing, you remember, was this one here, to where it looks like there's a stone in the urinary bladder. So 100% of the sound is reflected off the stone. It leaves none of the sound left to propagate more deep into the tissues, and so you get this strong shadow emanating from this stone inside the urinary bladder. Posterior enhancement, on the other hand, looks like this. Now we have a gallbladder. There's liver, there's the diaphragm again. This is liver, this is gallbladder. But now look at the tissue deep to the gallbladder. Is there a shadow, or is it actually brighter? It's brighter. That's an artifact called posterior enhancement, okay? And I'm going to try to explain this. Usually I draw this on the whiteboard, which helps, but I can't really do that. So let's imagine, the best analogy I've ever come up with to explain this has to do with football. Okay. And so if I have, let's say I have my football team, and I have all of my, I'm going to have a kickoff, okay, right at the beginning. And I have all of my 11 guys lined up here on the 35-yard line, ready to go. And my kicker comes out here and he kicks the ball down in here. So as soon as he kicks the ball, the other team's waiting at this end to receive the ball, okay? But as soon as it kicks it, then this guy has to go down here, and he's running down here, down the field, okay? The guy next to him is running down the field, and so on, all 11 guys. And you learned, if you ever played football, on the kickoffs, you have to stay in your lane, because you don't know which direction this guy's gonna run, okay? So this guy, you would think he'd run straight down here, but what if this guy runs over here? I'm getting beyond myself, but so you have to stay in your lane. So you have to stay over here on the side, and this guy has to stay kind of on the side near that guy, and so on as we go around here, right? Well, if I have these guys that are over here, half my football team is over here, and they're running through, and every time they hit a cell wall or the edge of the liver, or the edge of a vessel inside the liver, they are expending energy to fight through as they run down the field, all the stuff that's in the way, right? On the other hand, I get the other half of my team comes down this way, and everybody's at an equal part right in here until these lucky guys come down the field and they have it home free. There is nothing in the way, because we have this fluid-filled, anechoic fluid-filled cyst with nothing in it, Okay, so these guys, they get to run down the field, and by the time everybody gets at the same level down the field, which guys are going to have more energy? The guys that didn't have to spend all of their energy fighting as they get down the field. So that explains posterior enhancement. Okay, posterior enhancement is used medically to define a cyst. This is a cyst, basically a gallbladder is a big cystic structure. So posterior enhancement is used to define a cyst. Sonographically, a cyst is defined, if you look at this picture, you'll remember it. Sonographically, a cyst is defined as something that is well-defined, thin-walled, filled with anechoic fluid that demonstrates posterior enhancement. That's a cyst. And what do we know about cysts in the body? Almost every time, cysts are benign. Okay, so posterior enhancement is the opposite of posterior shadowing, and it helps us to define a cyst. Got it? Okay, those are artifacts. Now we're going to start off into organs. Okay, and again, this is a good book. I would recommend that if you're a fan, right? So, and if you're not a fan, you probably should be. Okay, so posterior or hepatobiliary system. We're going to start off talking about livers and such. Okay, this was from your anatomy book or a anatomy book. Okay, and here's the liver. How many lobes are in the liver of a dog or a cat? That's excellent, excellent feedback. 6. Okay, there's 6 lobes of the liver. Okay, some of them have some different subparts, but in general, there's 6 lobes of the liver. Okay, so that's looking at the dog from, you know, the portohepatus region at the liver. So here's another one looking at the other direction of the liver. Still got 6 lobes of the liver. Okay, the cool thing about ultrasound, and again, this is Brian Poteet's. We're going to make this as easy as possible kind of class, so you actually use it and remember stuff, right? I don't have a need to explain things more complicated to try to make myself look smart, because I'm not, right? And so we just make it as easy as we all can, right? And so the cool thing about all of this stuff and all of these liver lobe things is with ultrasound, you can't differentiate any of the liver lobes anyway. So that means you don't have to worry about remembering the names of them, right? The only one that with ultrasound, every time that you know the name of the liver lobe is this one here. See, this thing here says renal fossa. This is the right side of the dog. And the renal fossa is the part of the liver that sits right on top of the right kidney. So if put your probe on the right side of the dog, you find the right kidney. If you go just cranial to it, there's a hunk of liver that sits there, and that is the caudate lobe of the liver. Okay, so when you're ultrasounding, and this works every time, if you're ultrasounding and the owner's near you, or there's technicians or other doctors near you and they don't know how to ultrasound, then you start ultrasounding and you say, oh, there's the right kidney and there's the caudate lobe of the liver. As soon as you say that, they'll assume that you know the names of all of the rest of the lobes of the liver, but you don't, right? And so you just say that there, and it makes you look smart. And then I found out this too, is when you're ultrasounding, turn the lights off in the room and stuff like that, because the machines are colorful. They have, you know, lights and LEDs that come up from the keyboard, and the glow just makes you look really smart. Okay, so that's another thing you could do too. Okay, so inside the liver, we have the liver itself looks kind of, and I'll show you a picture in a minute, kind of a medium level rough architecture. The edges of the liver should be nice and smooth. Inside the liver, you're going to see prominent vessels that taper and get smaller as they extend to the periphery of the liver. And then I'm going to introduce this acronym that you start to need to know. And I remembered Slinky. This isn't actually how I remembered it back in the day, but I can't say how I remembered it. But it goes, if you remember Slinky, okay, it'll work. The spleen in a normal dog should be brighter than the liver, which should be brighter than the kidney. So spleen, liver, kidney, and a normal dog in that order of echogenicity. So here's a section of liver. So I see the diaphragm right in here. And I see this whole big hunk of stuff right in here is liver. Okay. And inside the liver, again, it's kind of a medium level salt and pepper echogenicity. This area right up in here is just subcutaneous tissue. That's that skin and fat underneath the skin. And then here's liver. And again, head's cranial's this way, caudal's this way. The dog's lying on his back. So this is ventral. This is dorsal. Okay. Back in this part, this is the stomach. The stomach lives just caudal to the liver, and this has got a little gas and maybe a little dog food inside the stomach. But this is all liver. Here's some blood vessels inside the liver, right in here, little ones right in here too. Those are blood vessels inside the liver. Okay, here's another section of liver. Here's the diaphragmatic margin. See how it looks like there's liver over here? Do you think that's real? It's probably not real. That's going to be the mirror image artifact. Let's see if I saw it back here too. Not really. So here it looks like there's liver over here, but we know that's probably mirror image artifact. So here's a hunk of liver right in here. And here is the stomach next to it. We can actually see rugal folds inside the stomach right next to the liver. Okay, here's, you already saw this slide, but here's again, here's diaphragm, here's liver, here's stomach with reverberation or comet tail artifacts coming from gas inside the stomach lumen. So I look at these vessels inside the liver. There's prominent vessels here. There's one kind of end on coming right out at you in the screen, and this one here. Here's another vessel. This one has a white wall. That's kind of fun. This one doesn't. Okay, so there's prominent vessels inside the liver that I can see periodically throughout the liver. Oop, getting ahead of myself. Okay, so here's another example of a liver. Okay, this time we're on the right side of the liver because there's a little bit of the gallbladder, which doesn't have hardly anything in it. And we know the gallbladder lives on the right side, but again, this is liver. There's a little gallbladder, which we're going to talk about more here in a minute. Okay, in fat cats, we talked about radiographically that fat, here's a dog or a cat, and I flipped him upside down in this particular case, or now I'll flip him back right. So here's a cat radiograph. Look at this, here's the liver, here's fat, okay? This is like a Texas-sized fat cat, right? So here's a whole bunch of fat, which isn't unusual, okay? So here's a whole bunch of fat in his retroperitoneal space. Here's a whole glob of fat in the falciform fat. He's got a lot of fat in his mesenteric area. There's fat all over this cat, right? People like fat cats. I'm not sure why that is, but they do. They have fat cats, okay? And so because radiographically has a bunch of fat in here, that makes the X-ray actually really pretty. I can see the edges. The surface serosal detail is really good. Okay, throughout this abdomen. The edges of the liver are well defined. If I'm looking at this animal here, is the liver normal in size, in shape, or is it too big or too small? What do you think, just radiographically? Well, let's think about the rules that we use to assess liver size. Oh, well, we said that the stomach axis, we use the stomach axis to assess liver size. So here's the stomach. And again, that axis should be somewhere that's perpendicular to the spine or parallel to the costal, to the ribs. So it's probably okay. The other thing we said about liver size, here's the liver. It said the liver should extend how far back? Kind of to the edge of the costochondral junction. So right in here to the edge of the liver, or to the edge of the ribs. Is it doing that? Yeah, it is. So the liver is actually normal in size and shape. Compared to the degree of fatness of the cat, the liver looks small. But when we said, how do we assess liver size? Nothing came up about fat. Okay, so this is just a fat cat. In comparison to the degree of fatness, this cat's liver looks small, but in reality, it's not. It's just the cat's fat. Okay, so how do I get back to where I was talking about? Well, here in this ultrasound image, here we have liver. And above it, what do we have in this fat cat? And that's why I flipped it over, because if you're geographically challenged now, it will make more sense, right? So here's liver, probes up here somewhere. Here's liver. Okay, here's the edge of the liver. What is all this stuff right in here? Right in here. That's all falciform fat. That's just a fat cat, okay? And very commonly, I'll see veterinarians that don't really know what they're doing with ultrasound, and they think the cat has a hepatic mass. It's got a mass in the liver, and they end up sticking it, and all they get is fat, and they get frustrated. Well, how could a hepatic mass be fat? And that's because it's not a hepatic mass, it's just fat. okay? And so don't get confused on fat cats of a mass that's in the liver, because that's just a big glob of fat. Okay, inside
Should
the liver.
you
Yep, go ahead.
aspirate it anyway just to make
Yeah,
sure it's not a small mass?
yeah, you're not going to hurt anything by aspirating it. No, not at all. How do you differentiate once you aspirate it and you put those cells on the slide? How do you differentiate it? Do you have to send it out to see if it's fat or not? No, if it's fat, it never will dry, right? And if you stain it, it just washes away. Okay, so you can differentiate as soon as you blow it on a slide, you know it's fat. Okay, okay. So inside the liver, there are different vessels that live inside the liver. And if you remember from anatomy, the liver has 3 blood supplies. But again, what class is this? This is Brian Poteet's. We're going to make this as easy as possible, clinically applicable class that you're not going to get fed a bunch of BS and stuff you don't need. You're going to get stuff you will use every day. Okay. And so what I tell you is, yes, I know the liver has 3 blood supplies. It has portal veins, it has hepatic veins, and it has hepatic arteries. On the other hand, I know that sonographically, I will never see hepatic arteries, so I don't worry about them. Okay, so sonographically, even though the liver really has 3 blood supplies, we consider it to have 2 blood supplies, which consists of portal veins and hepatic veins. And remember, the portal veins, what do they drain? Anatomically, what do they drain? They drain the bowel. So they drain the duodenum, the small bowel, a little bit of the colon, okay? So it takes all this nutrient-rich blood that's been absorbed from the small bowel and some fluid from the colon, and it takes that nutrient-rich blood to the liver and then branches inside the liver in every direction, arborizes like a big old tree inside the liver, okay? And it gives those nutrients to the liver cells, the hepatocytes, and lets the hepatocytes do their job about digesting and sorting and lipids and proteins and stuff like that, right? So that's portal veins. The hepatic vein inside the liver. Well, the hepatic veins inside the liver is the way that the liver gets rid of its blood. So all this blood coming from the portal veins and the hepatic arteries goes to the liver, and somehow the blood has to get back out of the liver. So the hepatic veins drain blood out of the liver and dumps it back into general circulation into the caudal vena cava, right? The hepatic arteries, the ones you'll never see, they deliver oxygen-rich blood to the liver so it can stay alive, but you don't see them. So the cool thing is that you can differentiate sonographically almost all the time a portal vein versus a hepatic vein. And you need to know this. And the key is that portal veins tend to have white walls. Hepatic veins don't. So anytime you see a vessel inside the liver and it has a white wall, you can bet it's a part of a portal vein. It's a branch of the portal vein. The hepatic veins don't. So if I'm looking at this here and I see here's liver, right? And I look at this big vessel inside the liver, would you bet that's a portal vein or a hepatic vein? It's a portal vein because it has white walls, okay? Portal veins have white walls. You should know that. Then we have vessels that live outside the liver in the porta hepatis region. And again, we have the main portal vein coming into the liver, draining all this nutrient-rich blood, taking it inside the liver. It's a flaccid tube. You're going to follow it cranially into the liver. And once it gets into the liver, what's it going to do? It's going to branch in different branches all inside the liver. And those branches of the portal veins inside the liver have white walls. Okay. On the other hand, there's another blood vessel that drains the abdomen called the caudal vena cava. The caudal vena cava doesn't go into the liver. It goes dorsal to the liver and goes to the heart. And so it never really enters into the liver, doesn't branch inside the liver. Okay, so next we have, let's see if I have, okay, here's a crappy picture, but if you look here, here's part of a portal vein coming in here. And so we have all this nutrient-rich blood, and if I could follow it cranially, it's gonna go into the liver and it's gonna branch inside the liver. There's another vessel underneath it, more dorsal, and if I follow that branch cranially, it never goes into the liver, it dives underneath the liver. That's the cava. Okay, so now we got to talk about hepatic vascular disease, and this is a fantastic place to quit. So that's what we're going to do. Okay, so we're going to pick up right here tomorrow. And we're doing fantastic as far as time goes. So everything's looking good, even though we had a little bit of a hiccup yesterday. So any questions here at the end of the day about beginning of ultrasound and what you're learning? Nothing that you can think of? Is everybody still, the fun meter is like pretty high? Yeah, kind of. Okay. Well, we're making as, this whole COVID thing is weird, but we're trying to make the best of it. All right. Okay. So everybody have a good day. We'll see you tomorrow at 10 a.m. and go from there. Ethan, I will try to send you the recording once it renders itself on this end. Okay.
Okay, that sounds good.
Yesterday's I'm not going to send because it's not worth sending.
Mm-hmm.
Okay.
Okay,
All
sounds
right.
good.
Y'all have a good one. I'll talk to you tomorrow.
Thanks, you too.
Thanks, you too.